Sometimes, when a root canal instrument breaks, it doesn't just break, it vanishes. It slips past the tip of the root and ends up inside the maxillary sinus. And at that point, it's no longer a dentist's problem, it becomes an ENT surgeon's job. When I first read about this case, I actually stopped and reread the paragraph. Every dentist has heard horror stories about broken files, but a fragment traveling through the root and disappearing into the sinus? That's the kind of complication you never want to meet during your shift. The patient was a man in his early 40s. Let's call him Andrew. Office job, active lifestyle, evening runs in the park. He came in with a familiar complaint, an upper molar that sometimes aches, sometimes doesn't. The tooth had been treated years ago. Old filling, occasional pain on biting. A routine story, right? The decision was simple: retreat the root canals. The dentist accessed the tooth, located the canals, began mechanical preparation. Everything was calm. Andrew lay back with headphones on, relaxed. Nothing felt out of the ordinary. And then that moment, every endodontist recognizes instantly. A subtle click. Not loud, but unmistakable. The instrument no longer moved the way it should. It felt shorter. The file had fractured. That alone is stressful. Usually the fragment stays inside the canal, already a difficult situation. You try to retrieve it, bypass it, sometimes leave it if it's stable. But this time, something was different. As the dentist gently irrigated the canal, Andrew suddenly said, "Doctor, I felt something move, like it went deeper, up here," pointing to his cheek beneath the eye. Not dental pain, something else. A periapical X-ray was taken immediately, and the canal was empty. No fragment, no metal. That's the moment when you stare at the image and think, all right, then where did it go? A cone beam CT scan answered the question. There it was. A small but sharply defined metallic object resting on the floor of the maxillary sinus. A few millimeters long, shiny, undeniable. The file had passed through the apex of the root, penetrated the thin sinus floor, and ended up inside an air-filled cavity connected to the nasal system. For Andrew, it still felt like routine dental treatment until the dentist explained, this part of the instrument is no longer in your tooth, it's in your sinus, and removing it will require an ENT surgical team. The maxillary sinus is an air cavity inside the upper jaw. In many people, the bone separating upper molar roots from the sinus is thick, but in others, it's paper thin. Sometimes the roots practically protrude into the sinus. Old infections, chronic inflammation, anatomical variation, all of this can weaken that barrier. A tiny defect forms, and if a file fractures at exactly the wrong moment, the fragment can be pushed straight into the sinus by irrigation pressure or instrument movement. At that point, it's not just an inconvenience. It's a foreign body inside a cavity connected to the respiratory system. Left untreated, it could lead to chronic sinusitis, persistent inflammation, facial pressure, headaches, foul nasal discharge, or worse. So the case was escalated properly. Andrew was referred to the hospital. An ENT team performed an endoscopic procedure through the nasal passage. Using optical instruments, they located the metallic fragment and carefully removed it from the sinus. Not through the mouth, through the nose. What's unsettling is that Andrew felt mostly fine. Mild discomfort, slight pressure, nothing dramatic. And yet, inside his head, a metal fragment had been sitting in his sinus, fully capable of causing long-term problems if ignored. Cases like this are rare. Most dentists will never encounter a file migrating into the maxillary sinus. But the fear of instrument separation is not exaggerated. Endodontic files work in narrow, complex spaces, often millimeters away from sinuses and nerves. And sometimes all it takes is a single metallic click to turn a routine dental visit into a multidisciplinary surgical case. A person comes in just to fix a tooth, thinking about work, groceries, dinner plans, and leaves with a referral to an ENT surgeon because part of a dental instrument is now living in his sinus. Every time I pick up a thin nickel titanium file and approach an upper molar whose roots sit close to the sinus, this story comes back to me. Because in dentistry, the distance between a normal appointment and a case from a textbook is just one broken millimeter of metal.